Right. So we're going to talk about modules 8, 9, and 10. And module 11, I'll do a little brief one as well, because module 11 will be on the final exam. But so basically SIRS, sepsis, tissue integrity, and clotting. So it all sort of ties hand in hand. It ties together really well. Trying to figure out how to switch my screens. All right, so these are the exemplars associated with ATP, ITP, also known as, it used to be called ITP. It's now autoimmune thrombocytopenia. It doesn't really fit within, it's an autoimmune disorder, but it's the only place really to put the thrombocytopenia aspect of it. So it's very little covering. DIC, delirium, so some SIRS response, sepsis, septic shock, leading into MODS, all right, multi-organ dysfunction syndrome, as well as hypovolemic shock, then burns and tissue integrity, or we could reverse it with tissue integrity and burns, either way. All right, so I love this slide. I think it came from the book. It just shows the progression, just like the case study does, of a local infection that becomes systemic, which is early sepsis, which becomes inflammatory response syndrome, which is that SIRS, leading into severe sepsis, which some organ failure comes into place. And then when you have multiple organ failure, 2 or more, it's multiple organ system failure leading into septic shock, and a high mortality rate with these patients if you see them in the ICU. So it's really that early intervention that is most important for us to take care of with these patients, and it's identifying those cues. And often that's where the rapid response team came from. The book uses Muse and SOFA, which we'll go into, but really it's that early intervention, early indication, those cues of our patients when they are deteriorating, the subtle signs that we have to catch. So what is shock? It's that widespread, it's that abnormal cellular metabolism. So it's going into like a lactic acidotic type phase. And that's where our lactic level is high. It's anaerobic versus aerobic, when all the tissue organs aren't being perfused, or it exceeds the amount of oxygen that we have being delivered. Right, like I said, it states there, occurs when gas exchange and oxygenation, they're not sufficiently met, they're not equal. So it's a condition and not a disease per se, meaning it's not like you have thyroid disorders or you have cardiovascular disease. It's a condition, it's a state that the patient is in. And ideally, we get them out of that state. So it can affect all body organs too as well. So it's not specific to one place. So remember your pathophys a little bit, what infection is. That infection causes tissue damage, can lead to organ failure and death if not treated properly. So remember, infection, like if you cut your finger, paper cut, you're going to have some inflammation to weld off, to seal off that infection, to allow the macrophages to get there, to allow the platelets to coagulate, all right, to keep it in a one single site. So what happens then is it spreads, it evades that one single site for some reason, either overwhelming immunity, not well taken care of, things like that. So septic shock is there and of itself is a subset of sepsis. So if you go back to that first slide and you look at that transition from infection all the way down to septic shock and multi-organ dysfunction syndrome, you have SIRS and MODS that are involved in that, systemic inflammatory response syndrome and MODS. So when infection escapes that local controlled widespread area, that's where we have that massive inflammation, SIRS. Okay. With inflammation, we'll get into it. So one of the biggest things is prevention. If we can prevent this from occurring, then we're golden. But a lot of these patients come in sick, right? They'll come in with a UTI that's now systemic because they did not catch it, especially our older adults. I always say, a change in level of consciousness is not normal, right? And our elderly is often a sign of an infection of some sort, often UTIs. So a huge source of sepsis. So evaluating the risk. What do you mean evaluating the risk? Which patients are at risk? We have patients that are immunocompromised, patients receiving chemotherapy. So it's the education, stay home, mask up, wash your hands. Low grade temperature of 100.5, is a sign of infection in a patient who's immunocompromised. Whereas, the general population, you wouldn't send them to an ER. Using aseptic technique, when we're performing tasks, that can help prevent infection. Remove catheters. Anything that's inserted into the body that would not normally be there, the sooner we can get it out, the better. So remove those indwelling urinary catheters, remove the IV accesses, remove the ventilator, right? The tube feeds, the triple lumen catheters, which is part of that IV access lines. I was trying to think of some others, but oh yeah, like even like the ventilator. So that's why we have all those bundles, because those bundles are ways to track dwell days, is something, the term that you might hear, the days of insertion, or to track when they need to get out, be removed, that is, all right? And are we performing proper care when they are in the body using aseptic technique? So wean from the ventilator as soon as possible. There's microorganisms that get on that ET tube, that tracheal tube, and unfortunately, even though there's a cuff there, there's still secretions down there, and it slipped through into the lungs. They end up with ventilator-associated pneumonia. Muse, which I have a slide screen I will go over, it's similar to the rapid response team, but it's looking at cues for the nurse. And then the SOFA also is, it's an organ failure assessment. It's used in the ICU, the SOFA is, whereas the Q SOFA is a modified one that's used out in, the ward. I say the ward, the med surg floor, the surgical floor, the peds floor. So they're predictors. They're like that rapid response. So early detection saves lives. So here's the SOFA and the Q SOFA. So it's a sequential organ failure assessment, and the quick one, right? So in an intensive care unit or critical care unit, you're looking at all these. Looking at these results. So they're already in the ICU for a reason, correct? So you're looking at the bilirubin, the creatinine, coag studies, and arterial blood gases. So you're looking at the ability for oxygenation, coagulation, liver, elevation, bilirubin elevated, hypotensive, requiring that vasopressor support to keep that MAP greater than 65, any abnormal GCS, and then your creatinine is elevated or urine output's less than 500 a day. Right. So they're considered abnormal, these parameters, right? Platelet counts less than 100, they're at risk for bleeding, right? Or they're probably utilizing all their platelets trying to clot off. And that comes into play with DIC. So, and each would receive a score of 2 or higher. So like it says, a score of 2 or higher in any system indicates they're at increased risk for organ failure, poor outcome, or death, right? The quick SOFA is for outside, right? The ICU. There's 3 parameters because you're not routinely drawing ABGs in the med surg floor. And really, you would be doing your CNS, but their protocol is the systolic blood pressure less than 100, respiratory rate, their tachypnic, and any change in mental status. So any patient with a score of 2 or 3 require additional assessment, then using the SOFA. So you're going to call an RRT with that. You have at least 2 indicators, right? And they'll probably get an ICU stay. Your Muse is this is directly from your book. It's also another formula that you can use. It's the early warning system. All right. It's for detecting in adult patients that they develop critical illnesses. So as you can see right below here, if your score of your patients 1 to 2, you perform every 2 hours observations, right? And inform the nursing charge, your team leader, whatever they call it. If they have 3 or more, you're going to have to increase their frequency. And most of these patients should be, at this point, either in a step-down unit or an intensive care unit. At what point do you notify the provider? They say this, the house officer or duty doctor, if your score of your patient is 4 or more. So they're going to be in an ICU. Okay. So you look at it, they get a 0 if the respiratory rate's normal. The systolic blood pressure is fine. If they're alert, we're using your ABSN. If their temperature is normal and their urine output's normal. Here's your ones on this extreme, here are the ones in that extreme. So look at your urine output. Obviously, we indicate urine output, they're starting to have a trend down if their urine output's less than 45 milliliters an hour, then to 30 and then to 10. Okay. So look at this, you add them up, your scores, 1, 2, 3 points. You get 2 points here. Let's say their respiratory rate's less than 30, but less than 40, but more than 30. All right. So that's 36. They're going to get a 2. Their temperature is cold, right? They're clammy. Their blood pressure is extremely low. They're at a 6. Okay. So look at that Muse. Are you going to be tested on the Muse? You'll be tested on the theory of Muse and your patient with the Muse score of, not calculating out a Muse score, because you're going to have that schematic with you when you're in a unit or a floor, somewhere in your charting system. Always know who's at risk. And I sort of brought it up earlier, but these patients are classic. I think you guys, this ties the entire semester together. So nutrition, as we all forget about nutrition often, but early nutrition is key, right? Malnutrition doesn't allow for wound healing, for strength, fermentation, everything. The gut is put at risk for infection. So malnutrition, somebody who's anorexic, cachectic, who do you think of? An elderly patient, a patient who's receiving chemotherapy, any type of patient that's malnourished, HIV, AIDS patient, anything with immunosuppression, large open wounds, obviously mucous membranes and fissures, any GI ischemia, right? I mean, if the patient's throwing a clot to their small intestine or large intestine, they're at huge risk for infection. Invasive procedures. What are invasive procedures? Triple lumen catheters, catheter-related bloodstream infections, your CAUTI, your VAP, patients with cancer, unfortunately, and then the rest of them. Okay, alcoholism. Why alcoholism? So we used to always tell our patients in oncology that they could not drink alcohol when they're undergoing chemotherapy, and they shouldn't drink it anyway. Why do you think? Even a beer a day or anything else, because alcohol causes immunosuppression, right? It decreases the white blood cell effects. It causes a natural nadir, a lower white blood cell count. So that, in addition to chemotherapy, puts the patient even at greater risk for being neutropenic. All right. So always assess them, right? Do they take drugs? Or it could be street drugs, or it could just be steroids, right? What medications do they take? And this is just your typical physical assessment, the cardiovascular, respiratory, skin, and kidney and urine system. Look at your lab tests, right? Serum procalcitonin levels, increasing serum lactate levels. I think the book says greater than 2. Hang on. Sorry about that. I know you can't see, but my dogs just all walked in the room. A normal or low white blood cell count. Why would they have a low white blood cell count? They're immunosuppressed. Their body can't, their bone marrow can't keep up with the production of white blood cells due to overwhelming mass infection, right? Decreased segmental neutrophil levels with a rising band that was the immature white blood cells. So if you become an oncology nurse, you'll look at your bands and your neutrophils. So segs and bands. Presence of bacteria in the blood when we draw those cultures, and other lab findings. Low platelet count. We'll go into DIC a little bit. Your fibrinogen levels are low, and your hemoglobin hematocrit are low. So the Surviving Sepsis campaign, there's a 3-hour and 6-hour bundle, and then the book has the 1-hour bundle as well. I want you to review those and understand there's a lot of protocol and criteria with getting IV antibiotics on board, getting laboratory results done, getting your blood cultures drawn, fluid volume resuscitation. So early identification, you look at the 3-hour and 6-hour bundles, they have mild hypotension, just a low urine output. If you go back to that Muse score, if I can get back to it real quick, the Muse is your early warning indication sign. Just a low blood pressure, 99, which hopefully alerts you to something's wrong, and that urine output less than 45 milliliters an hour. So early indications, early identification saves lives, right? Keeps patients out of the ICU. They're mildly tachypneic. Their temperature can be varied. They can be cold or warm. Remember, with early sepsis, early on with SIRS or anything else, they are hyperdynamic, meaning their blood pressure is, because the body's compensating to try and get that cardiac output. So they might be warm and flush. They might have a stable systolic blood pressure, right? With tachycardia to try and keep that cardiac output up. But that warmth is that vasodilation as well. systemic inflammatory response. And then inappropriate clotting. So this is hard to read, but the 1 hour bundle of management, within 1 hour, you suspect a patient is sick, they have sepsis. They measure that lactate level. Always obtain cultures before antibiotic administration. You guys saw that on the case study. And then administer broad spectrum antibiotics. They have specific antibiotics that broad spectrum because they don't know what they're covering yet. And then fluids, right? For a lactate level greater than 4. And vasopressors if necessary, right? To keep that mean arterial pressure greater than 65 to perfuse the vital organs. What are the subtle clues? I already sort of said it. So cardiac function is hyperdynamic. There's pooling of blood and they have capillary leak. They're oozy often. Now, not in the early stages of sepsis, but as the patient deteriorates, they can be oozing out of most orifices, oozing just from the skin. It's to look at that. But early on, they feel warm. They have increased systolic blood pressure. Their heart rate's up and their cardiac output trying to get it out. The white blood cell might be normal, but the bone marrow is not going to end up keeping up with that production of white blood cell production of mature white blood cells and macrophages that can actually ward off infection, right? Their O2 sats are low. Their respiratory rate starts to become tachypnic. Their urine output starts to decrease. They might have some mental status changes. Look at that muse. It's a rapid progression. It's just a subtle time frame that we can catch this and get antibiotics on board, that 1 hour bundle. All tissues are involved, they become hypoxic. The delivery of oxygen is poor. The cells cannot uptake and metabolize oxygen the microthrombi forms. So your body initially with inflammatory response is going to start throwing out platelets and clotting. So it can cause insult and injury to organs. Early stages, when a patient's in sepsis and they're having the clotting disorder, we'll put them on heparin, right? To stop the clotting, to help make sure clots don't stick and form. Ultimately, once again, your bone marrow is not going to be able to keep up with the production of platelets, which is what you end up with, disseminated intravascular coagulation. So it leads to DIC and they start to bleed because then they have depleted their cells, their body's resources for platelets, and we have to infuse platelets, infuse fibrinogen, infuse clotting medications, vitamin K, other things like that. And then they all are going to be hyperglycemic due to the stress response, right? So they're going to end up on insulin. Once they get into septic shock, they're going to require vasopressor therapy. I assume you've seen it, hopefully in clinical, some using dopamine, levophed, epinephrine, norepinephrine, any of those medications to keep the mean arterial pressure greater than 65. What does that do is it returns volume of blood back to the heart, correct? But it clamps down the periphery. So you always have to check for perfusion in the extremities, but that blood is going to be returned to the heart by perfusing the fingers and toes. We used to call levophed, leave them dead. I don't think it's like that anymore, but it was a last resort, a ditch resort to keep and maintain volume in the body or maintain a cardiac output for some form of perfusion to the organs that are the vital organs, your brain, your kidneys, your lungs, your liver, your heart, okay? In septic shock, you have multiple organ dysfunction syndrome. That's more than 2 are involved. They have that pleural clotting. They can have uncontrolled bleeding. They can be bleeding for every orifice. They can be bleeding from their eyes, okay? And hypovolemic shock, because they're so vasodilated and they're capillary leak, right? And they have a hypodynamic cardiac function at this point. Their output is low. So we give them oxygen. We give them drug therapy, right? Vasopressors, anything that can help increase the blood pressure. Give them antibiotics. They're going to be on insulin because of that hyperglycemia. Fluids as well, obviously. We might have to give them blood, platelets, fibrinogen, heparin therapy early on prior to the bleeding. Oop, I don't know what that is. Oh, shoot. Sorry. Oh, there we go. I love this. Now the book will talk about SIRS really isn't an indicator anymore, but I think it SIRS is now more probably the rapid response team. So 2 or more of the following criteria was how we used to identify as SIRS, but SIRS is still part of sepsis. But you can look at these, okay? Low or high white blood cell count. Sepsis, you have a documented infection, whether it's a catheter, UTI, whether they had an appendix rupture or their bowel ruptured. You know, they had a diabetic foot ulcer that just became overwhelmingly infected. They weren't monitoring it at home, taking care of it, doing dressing changes, whatever. Or they just have poor immune system that's unable to control the infection that they have, or whatever their source of their infection was. Remember, with diabetic patients, they're at greater risk because they have poor perfusion. Right? They have a higher glucose rate, so they have a higher bacterial risk. Severe sepsis, it's associated with organ dysfunction, hypoperfusion, and hypotension, and then septic shock. So it's refractory, with refractory hypotension and hypoperfusion manifestations. And then MODS is failure of 2 or more of those organs. Okay. You have to support the body's sustained life. They might be on continuous venous dilation, right? It's 24 hours of fluid replacement with using dialysis at the bedside. And that's what nurses do. That you don't have a dialysis tech that does that. So ATP, it's really autoimmune. The body's attacking our platelets, right? Those antibodies attach and they attack and destroy the platelets, and also those in the spleen. They're destroyed faster than the body can be produced. And remember, platelets last, I think, what, 21 days? And clotting's impaired. So it's really an autoimmune disorder, and that's the best way to tie it in as they have an immune disorder. They might be immunocompromised as well. So ATP. DIC, though, is that initial extensive abnormal clotting, right? That clotting, those microthrombi that are being formed and thrown out there, depletes the circulatory clotting factors, right? So, clotting factor 7, 10, and platelets also. So you can bleed from many sites, and it's interesting to see, right? It's more likely to occur with sepsis due to the inflammatory response and an overwhelming infection. So like I said, initially we're going to treat it with heparin to limit the clotting. So we ideally are not using up all of our platelet and clotting factor resources. But if it progresses, and once it progresses, then we give clotting factors and platelets. It's not on this slide. Another just way to look at SIRS, okay? There's some indicators here as it goes down into septic shock. Burns. So real quick pause, let's switch to burns. Sorry. Burns patients can lead into, obviously they can have a septic shock as well and die and overwhelming, but they range in, in severity from a little sunburn, which many of us have already had, to life-threatening trauma. Okay. They have anatomical, functional, and psychosocial things that we're looking at, these changes with burn patients. Anatomical is where it's at, what burned. Functional, think about wound healing and contracture, loss of an extremity, and then the psychosocial aspect of it, just the fact of living with the scars or the loss of a tissue, psychosocial. So the extent of an injuries, the burn classification is based off the depth of destruction. Also, the degree of the burn, first, second, third, fourth degree of thickness of that burn. So when you look back at the book and you look at tissue integrity, this is just not even patho, it's A and P, but you look at your epidermis. So those superficial burns, it's the top layer of skin, right? They heal in 3 to 6 days. And then you have the superficial partial thickness, which you can read this. It has a longer healing time. And then the deep partial thickness. And then you get into full thickness burns. So skin can regrow if the dermis is still, parts of the dermis is still present, right? Our sweat glands, our oil glands, skin can regrow. But if the entire dermal layer is gone, skin can't restore itself. A lot of these patients will end up getting skin transplants. It's really neat if you can go into the OR and watch them. They'll take some from the thigh, if the thigh isn't impacted, and place it on the upper extremity. All right. Or they can take donor skin, or they can use animal skin. So subcutaneous is if exposed bone, tendon, and muscle can be exposed. So it depends on the extent and the depth of that burn. So the IGI doesn't really go into the Parkland's formula of fluid resuscitation, and I just sort of jumped ahead. But when I looked at the maintains fluid and electrolyte balance. But with functional, this is the functional portion of burns, we want to protect the body from infection, right? The skin is our protector. When there's a cut in the skin, we're at greater risk for infection. So if our skin is burned off, let's say it's a thermal burn or from fire or anything else, we're at greater risk for infection. It helps maintain our body temperature, maintains our fluid and electrolyte balance. Without that skin there, we lose very vital, nutrients. We lose fluids. We lose due to evaporation, right? Electrolytes. Skin allows for the perception of pain, which is why you might see a lot in ICUs. If you're in a burn ICU, if you get the ability to work in a burn ICU, they often don't sedate patients when they're doing their debridement. Psychosocial is obviously the self-concept, concept often, that doesn't make sense to me right now, often reduced as a result of a burn. So your self, Lord, I just forgot the word. Anyway, your ability to be confident in yourself, I'd say self-confidence is reduced often, right? The fear of what people are going to think about you. So anatomic, functional, and psychosocial. So you definitely need to know the rule of nines, all right? We're only looking at the adult, not peds. So, and the book, I don't think has any peds in it. But understand your rule of nines, be able to calculate a burn injury based off your rule of nines. You'll see it on the exam. Now, burn classifications. Like I said, the degree of the burn can be first, second, third, or fourth. It can be superficial or deep based off the thickness. How long were they exposed to the source? What was the cause of the source? Was it fire? Was it chemical? Was it thermal? Was it electrical? Was it inhalation? They're all different types. And obviously the depth of destruction and then like the heat source. What was the temperature? So from your book, this goes through obviously superficial, first degree, superficial, second degree, deep, second degree, third degree, and fourth degree. So what do you need to know? You need to understand, healing time, but that was on one of the previous slides. Let's see. Pain is important, right? And these are the patients that they do debridements without pain medications, at least from my experience in the past. Hopefully they've changed that because it was traumatizing, I think. Sometimes they'll go in the OR for debridement, depending on how bad the degree of burn is and the extent on the body, right? And then the appearance. So understand the difference in your first, second, and third degree burns and fourth degree burns. Superficial, deep, all right? And that first picture tells you as well, where I had the 3 different sections of skin. Classification of burns, you have minor, moderate, major. It tells you a little bit about it. This is directly from your book. It has a percentage of the total body surface area. Okay, that is involved. So electrical burns, including lightning, or if you're changing, you have an electrician that's outside working, I don't know, and they unfortunately touch a live wire. That electrical burn is internal and it has to have an exit site, but it's burning internal. What happens when you burn internally? What do you expect to happen? Well, there's muscle damage. It just depends on where the pathway is, but it causes potassium leak, right? Due to cells being destructed, everything else. Inhalation injuries, which is here, it's considered a major burn. Those patients are at great risk for what? Decompensation, respiratory failure. These patients need to be intubated because of the swelling that's going to occur, at least monitored acutely in an ICU for airway, maintenance. If you see singed nasal hairs, circumferential, open the mouth, if you see soot, anything else, they have had an inhalation injury. They're at huge risk for airway edema. It talks about children, which we don't have to worry about. All right, so once again, pathophys review, there's a chemical, electrical, radiation, smoke related, and thermal. So chemical would be like an acid, or you're working with, caustic chemicals and they spill on you, or, often people get them thrown at them I've seen that in the burn unit in Virginia when I worked. Electrical injuries can be from lightning strikes, or it could just be from an electrical true source that you have touched. Radiation, sun, those first degree, second degree burns, fall asleep laying out at the beach. Someone's drank too much. They pass out and they're alone. Smoke is the inhalation, and the thermal heat related, flames, liquids, and contact. So when I worked in the burn unit, we used to really be concerned on the 4th of July because people would put fireworks in their pockets and they were all drinking. This is in Virginia, Virginia Beach. And we've had injuries that way. So treatment, resuscitation, first emergent, acute, and rehabilitative. You need to know these, right? You're not going to have to calculate out the 8 hours to 24 hours and the remainder of fluids. It's the Parkland formula. It's in your case study. I want you to see it. It's not an IGGI for some reason, but the IGGI is focused on the acute, right? Not so much intensive care unit, but more of our acute units, med surg, chronic, conditions. So emergent resuscitation, it's in that continues for 24 to 48 hours. It depends on, so we're worried about airway, perfusion, right? Due to the extent of the burn, temperature regulation, pain management, and then just that emotional support. Emotional support carries throughout. It should, and even though it doesn't on these slides. So the acute is the healing phase. So first you're doing resuscitation, and with the Parkland formula, you're going to give a certain amount based off their body weight of volume and the extent of their burn damage, based on how much you're going to give immediately, 8 hours, first 24 hours, and the remainder of the time. That being said, these patients obviously need central line support, right? Especially if they have had burns on their extremities and you can't start an IV there, right? They might need an intravenous osseous IO access. You have to assess the patient to see what you need. So airway perfusion, temperature, pain, and emotional support. Then when we get into the acute healing phase, it's when those fluid shifts resolve, right? Initially, you're going to have a lot of fluid shift changes here, which can cause the hypotension, cause perfusion problems, fluid and electrolyte imbalances, elevated potassium from capillary cellular leak or damage to the cells into the interstitial fluids. Fluid shifts resolves. This says 36 to 48 hours after the injury, acute healing. Lasts until the wound closure complete. All the above continues as well. Airway, perfusion, temperature. You never forget any of that. Those are your ABCs. And then nutrition and wound care. So rehabilitative is wound closure to the highest level of functioning. Depending on the extent of burn injury, morbidity worsens. The greater the burn extents of total body surface area, the decreased likelihood of survival due to overwhelming infection, due to fluid and volume shifts. So non-surgical management, airway, pain, infection control, and wound healing. They aren't automatically started on antibiotics, but this only surgical management, the book doesn't even go into it, would be probably grafting and everything like that, grafts, wound grafts, skin grafts, to protect skin, to help with restoration, to help with wound contractures, to minimize that. So airway maintenance, pain control, infection, and wound healing. Pain control is important, right, from the get-go. These patients are not at risk for, at least in the acute phase of addiction, because they're having pain. All right, control the pain. Infection control, aseptic technique. If they're using Silvadine or any ointments or creams, they're placed on there for a duration of time. And then wound healing. It depends on what the extent of the burn, what type of dressings might be on there or not be on there. So what's not in this presentation, let me stop real quick. I'll go back, is talking about delirium. I'll add that to this next presentation that I'll post. But really, there's not a lot in the book on delirium, but it's talking more about differentiating delirium from, I just forgot the word. But delirium is common in the hospital, especially with the elderly adults, due to lack of sleep, right? Disorientation. So constant interruptions. So I'll add that on there, okay? Let me know if you have questions.